Good evening to our PSD fellows, members, and friends. So tonight, we welcome you to our first PSD Select for 2022. But before we start with our updates, let us place ourselves in the presence of the Lord. Dear Almighty, ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn today. We pray that you bless all the committees in charge, that they may also be able to fulfill their tasks responsibly, that the objectives they may have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witness of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord and Savior. Amen. So good evening, everyone. We as the PSD officers have prepared for you a monthly updates. So tonight, this is our first update, although February na. Wala tayong January, no? So we have our February edition of the PSD Select. So can we watch our objective?
Philippine Society of Diabetologists. The mission of PSD, the pursuit of excellence in diabetology. The vision of PSD, excellence in diabetology. Objective of PSD, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
So we welcome you all to PSD Select 4. So this is its purpose and objectives. Tonight, we have our sponsor for tonight is Werwag. Their topic is diabetic neuropathy, and our speaker will be Dr. Melanie Duran. The second topic will be the updates on 2021 American Diabetes Association by Dr. Ernesto Ang. This will be followed by a Q&A. So can we call now our sponsor, our Werwag Pharma.
Good evening, doctors. Good evening, Dr. Marcy.
Good
So
evening.
first of all, po, we would like to thank you po, PSD for giving us the opportunity to be your pharma partner for tonight po, for this PSD Select 4 lecture series po. We truly look forward po for this kind of occasions where we're able to partner with you and share updates po with you coming from our experts. So Warwag Pharma is a German pharmaceutical company po with subsidiaries worldwide. Our company develops and sells biofactors preparations such as vitamins, minerals, and trace elements po. The range of our products that we have in our company comprises both prescription, OTC, and food supplements po. Our products are used to treat diabetic comorbidities po, such as neuropathy, specific to nerve damage, as well as cardiovascular and neurological diseases. So as we all know po, due to lifestyle and a healthy living, diabetic patients are increasing year on year. And the most frequent complication of diabetes is diabetic neuropathy that may lead into complication if not treated early. So diabetic neuropathy are largely underdiagnosed, overlooked, inadequately treated, and sometimes a forgotten complication. So we at Warwag Pharma po is embarking to reach out a lot of more doctors like you, where our products po could be beneficial to your patient's quality of life. So we hope that the lecture this evening with our invited speaker will help you in the assessment, diagnosis, management, and of course the pathogenetic treatment of diabetic polyneuropathy. So together with you po and Warwag Pharma, let us empower po health-conscious people with highly effective solutions to prevent and treat lifestyle diseases. So thank you and good evening po.
Thank you, Boss Mike. So I want to introduce to you our speaker for tonight, a faculty of ISDFI and a faculty also of the Diabetes Education Training Program, PADE and ADNEP, Board of Trustee of the Philippine Association of Diabetes Educator Incorporated, and a consultant diabetologist in Tokyo Health Link and Calamba Medical Center. Tonight, I'm proud to present to you Dr. Melanie Duran.
Good evening to each one of you, my friends, my colleagues, my brothers, my sisters. And hindi ko na po kayo iisa-isang i-acknowledge, no? And in behalf of Warwag, we would like to thank you for the opportunity that you joined us tonight. I promise you that hindi po kayo magsisisi. This will be worth your time. These are the following outcomes you want to achieve. You will be able to update yourselves on the current epidemiology of diabetic neuropathy. We will review together the pathophysiology of diabetic neuropathy. We will discuss the importance of comprehensive food assessment among people with diabetes. We will also assess the utility and limitations of available therapy in the management of diabetic polyneuropathy. And lastly, we will evaluate the evidence of theophyllic acid in the treatment of early and advanced diabetic polyneuropathy in primary care setting. First part will be tackling about the epidemiology of diabetic peripheral neuropathy, also called as DPN. We all know that diabetes is already established to be a burden to most economies worldwide. And according to the International Diabetes Federation, and we have a representative in our midst in the, itago po natin sa pangalan, Ms. Leyden Florido. She is the WPR IDF representative. The Philippines currently has 7 to 8 million Filipinos with diabetes, and half of them are undiagnosed. Okay. So DPN is a silent complication with deleterious consequences on the quality of life of people with diabetes. In this recent review in 2020, they reported a prevalence rate of DPN on the different Southeast Asian countries, ranging between 33% to 58% among patients with diabetes. Now, a recent study in 2016 by our colleagues in the Philippine General Hospital, they were able to show a DPN prevalence of 58% based on nerve conduction studies. So, friends, there is a call for urgency in making the early diagnosis of DPN. And that's why we entitled this module A Call to Action. Advanced DPN with foot ulceration and subsequent amputation is associated with a 5-year mortality of 73%, exceeding that of patients with end-stage renal disease, stroke, myocardial infarction, and vitrectomy for proliferative diabetic retinopathy. You will notice, my friends, before patients with diabetes, with DPN, with foot ulceration, before they die, most of them suffer quietly from diabetes distress or depression. And we also need to address these concerns by using readily available and free online tools which we can share during the this. Moreover, a systematic review by Dr. Kersey, published only this year, 2021. He made a systematic review showing a 66 to 71% prevalence of DPN in pre-diabetes. Again, in pre-diabetes. So my friends, as more Filipinos with diabetes continue to increase in the coming years, we really have to update ourselves with the proper knowledge, skills, and attitude on diagnosis and management of DPN. So this is the basis, the backgrounder, or rationale for conducting this RTD among diabetologists. Let us move on to the second part, which is the pathophysiology of DPN. This picture may look familiar to us because it was adapted from the Banting lecture in 2006 by Brownlee. Let us review. Hyperglycemia or glucotoxicity and dyslipidemia or lipotoxicity result in a substrate excess in mitochondria, leading to mitochondrial dysfunction and overproduction of reactive oxygen species, ROS, and reactive carbonyls. Marami po sa audience natin marirecall yung mga ginawa nilang concept map. ROS and carbonyl stress-mediated nuclear DNA damage activates the PARP, PARP. In turn, it will lead to depletion of oxidized nicotinamide adenine dinucleotide ATP ratio. Will in turn inhibit your GAD-PH, glyceraldehyde 3-phosphate dehydrogenase. Now, the inactivation of the GAD-PH inside the nucleus, okay, in this case, the nerve cell, the nucleus of the nerve cell, will activate key pathways leading to the development of DPN. So, di ba, ito yung polyol pathway, hexosamine pathway, PKC activity, and your advanced glycosylation end products, or HE. And reactive carbonyls also cause endoplasmic reticulum stress, ER stress. happens in pre-diabetes and pre-diabetes, added with the inflammation, okay, it causes impaired insulin signaling. All of these risk factors and pathway converge in the activation of stress and inflammatory pathways. Your nuclear factor kappa B, your JNK, your AMPK, and COX-2. So everything will lead to vast changes in gene expression, upregulation of your cytokines, leading to apoptosis or cell death. Now, we all know that we have to control gluco and lipotoxicity. In addition, there are options. You may now look on the left lower side of the screen depicting your mitochondrion. Where are green boxes, right? There's your green boxes labeled alpha lipoic acid. So these are options for pathogenesis-derived treatment, okay? And if we give this treatment, it will stop the processes, the downstream, that's the crossbar in the red line, okay? It's able to block the corresponding pathways, okay? So review lang po yun. Okay. So the reason we had to review that, pathobiology by Brownlee, because evidence-based po ang treatment, and we will connect it later with the evidence-based treatment. Okay? Let's move on to comprehensive food assessment, and this may be new to you, and if you are interested to have soft copies of the journals used in this module, we can provide you with a soft copy. Let us begin by sharing with you guys. This is a validation of the Filipino translated version of the Michigan Neuropathy Screening in the PGH, Philippine General Hospital. Okay, so here, based on the history questionnaire, this is self-administered by the patient. Okay, so nakatagalog version na po siya. Responses are added to obtain the total score. The patient may respond yes to items 1 to 3, 5 to 6, 8 to 9, 11 to 12, 14 to 15, and their response of yes will count as 1 point. A no response on items number 7 and 13 counts as 1 point. Now, item number 4 is a measure of impaired circulation. Item number 10 is a measure of general asthenia and are not included in scoring. Now, the investigators in PGH did not reveal the scoring information, okay? It was eliminated from the patient version to decrease the potential for bias. Now, this is what the healthcare professional will do doing the physical examination. In the foot examination inspection, we will inspect the feet for evidence of deformities, dry skin, calluses, infections, and fissures. So deformities include flat feet, hammer toes, overlapping toes, hallux valgus, joint subluxation. Prominent ba ang metatarsal heads? May bunions pa. So meron bang Charcot foot or middle convexity? And of course, amputation in the past. Each foot with any abnormality will receive a score of 1. Each foot will be inspected for ulcers, and each foot with an ulcer will receive a score of 1. Now, going to the muscle stretch reflexes or ankle reflexes, we will be using a reflex hammer. So the ankle reflexes will be elicited in the sitting position with the foot dependent and the patient relaxed. Okay? The foot should be passively positioned and the foot dorsiflex slightly to obtain optimal stretch of the muscle. So we should percuss directly the Achilles tendon. Now, what are we going to do if the reflex is absent? We should be performing the Gendrasic maneuver it is review lang po. Gymnastic maneuver is we instruct the patient to clench the teeth and hook the fingers together and pulling apart. Okay? So while the patient is doing that, you do the reflex. Okay? If the reflex elicited with the gymnastic maneuver alone were designated present with reinforcement, we will score it as 0.5. Now, in spite of the gymnastic maneuver, if the reflex is absent, even in the face of doing that maneuver, the reflex will be considered absent and will be scored as 1. So may extra step the gymnastic maneuver to give a score of 0.5 or right or left reinforcement. Okay? For the vibration sense, alam na rin po natin to, review lang tayo. We will be using 128 Hz tuning fork over the dorsum of the great toe on the bony prominence of the distal interphalangeal joint. Okay. Now, very critical, how many seconds ba hihintayin natin? So in general, we should be able to feel the vibration in our hand for 5 seconds longer than a normal subject. Okay? If the examiner is able to feel the vibration 10 or more seconds, okay, then therefore, vibration was considered release. Ibig sabihin, 10 or more seconds, walang sinasabi yung patient na hindi na niya nararamdaman. Okay? Now, okay. Anyway, we'll be showing you some videos later. Okay? Now, the total possible score will be 8 points. And in the published scoring algorithm, a score of more than 2.5 will be considered abnormal. I forgot to tell you guys, what if the vibration was felt, okay, pero more than 10 seconds, okay? Diba gusto sana natin magpa-positive siya pag more than, ano? Okay. Kasi pwede rin kasi siyang score as 0.5. Kasi meron pa rin namang naramdaman yung patient pero reduce na yung vibration detected. Okay? Now, kung gusto nyo pong mas madali, okay, we can ask Forward to provide you with these tools. These tools were taken from Germany, where Gamma is manufactured. And this was developed for the CPG, for the clinical practice guidelines to be used by the members of the German Diabetes Society, yung counterpart ng ating Diabetes Philippines. Okay, so this is the clinical examination to be done by us, healthcare professionals, while this one naman will be self-test for patients with diabetes. So these are in English. Okay, so at this point, let's listen to and watch these videos.
Hello, my name is Colin Brister and I'm a fifth year medical student here. Can I ask your name, please?
Yes, Dennis Matthews.
Okay, Dennis. Now, I understand you have diabetes and I've been asked to examine your legs today. That'll just involve me checking the sensation in your legs and checking some pulses in your legs and then watching you walk afterwards. Would that be all right?
Yeah, that's fine.
Okay. First of all, if I could ask you to just lift your shorts up a little bit. That's excellent. I'm just going to have a look at your legs from the end of the bed. All right? Okay. Okay, I'm just going to check for any hair loss, any skin changes, any redness or ulcers. Okay, I'm just going to have a look between your toes, Dennis, all right? Okay, and I'll also check the bottom of your feet. That's great. Can you lift your heel up? And the other one? Brilliant. Okay, Dennis, I'm just going to have a feel of your legs now. That'll just involve me feeling down your legs and feeling the pulses. Is that all right? Okay. Okay, Dennis, I'm just going to have a feel of your toes now. I'm just going to press gently on the bottom of them. Okay, I'm now going to test the sensation in the bottom of your foot with this monofilament. It feels like this. And again, I'd like you to close your eyes and let me know if you can feel it on the left or the right hand side. Okay, all right? Right, left. Okay, I'd like to test vibration in your feet now. And that's going to involve me placing this tuning fork on your feet with your eyes closed. I'd like you to tell me if you feel the vibration and tell me when it stops, right? So it normally feels like this. Okay, all right? So close your eyes. Yeah. And it stopped. Yeah. And it stopped. Okay, Dennis, I'm just going to test your sense of joint position now. So with your toe, this is up, and this is down. You close your eyes and tell me whether it's going up or down. Okay? Up, down, down, brilliant. Up, down, down. Okay, Dennis, I'd just like to test your reflexes now. So I'm just going to tap the back of your leg with this tendon hammer just gently. Is that all right? Yeah, that's fine. Okay. Could you just lift this knee up and flop your leg out to the side? Brilliant. Great. Okay, Dennis, I'd just like to watch you walk now. So if you could come off the bed, and if you could just walk across and front of the bed. Very much for letting me examine you. No problem. So this was Dennis Matthews, and today I performed a diabetic foot examination on him. On examination, there is no neurovascular deficit suggestive of diabetic disease. I could complete the examination by performing a full neurovascular assessment, measuring the capillary blood glucose at the bedside, and advising Dennis on appropriate foot care.
So guys, we hope that those two videos were able to refresh our skills in doing the comprehensive foot exam. Now let us move on to second to the last part, which is the therapy of diabetic polyneuropathy. So after doing the foot assessment and we found that it was positive, of course, we have to also advise our patient on lifestyle modification and control of the other risk factors, okay? And also assess for other comorbidities and the potential for drug-to-drug interaction, especially in the elderly who are already into polypharmacy. So let us say, can you see my arrow po ba? Or not? You can see the arrow po?
Yes po.
Okay. So let's say you did well with your foot assessment and wala hong symptoms talaga ang patient na pine-present pero positive ang assessment natin na meron siyang tinatawag na loss of protective sensation or even beginning signs of polyneuropathy. And in some cases pa nga ho, with high index of suspicion, okay, pwede kasing magpa-test din tayo with nerve conduction velocity studies. Kung talagang meron tayong high index of suspicion, hindi ho positive ang foot screening na test natin, of course, we know it's very expensive. So, limited for the patients that will be really needing it. Okay? So, let's say, ang category ng patient is asymptomatic BPN. Or let's say symptomatic pero non-painful. So, more of like nagmamanhid, no? So, it's not pain, but it's causing decreased quality of life, maybe affecting the sleep of our patient or their work. Okay? So pagka ganito po, we can give them lipoic acid. Okay? And this is a pathogenesis-derived treatment. And we should give it very early upon diagnosis. And we also have a lot of patients na merong painful presentation. So ito talaga yung painful. Doktora, masakit, hindi ako makatulog. Mas nararamdaman ko na siya, lalo na sa gabi pag wala na akong ginagawa. Sometimes naman during the day, ganun ka-severe ang kanilang neuropathy, so talagang affecting their day-to-day activities, activities of daily living. Okay. So in this case, we can combine initially with analgesic treatment. Okay? At dito, sanay na rin po tayong binibigyan ng ating patient. Okay? So for the painful kind of neuropathy, we've been giving pregabalin or gabapentin or even tramadol. Okay? Now, for very severe cases, we even can refer to our rehabilitation counterparts. Okay? Now, in every patient po, iba-iba po talaga ang effect. Okay? So we really have to be careful in optimizing treatment to every patient. It should be individualized and carefully up-titrated. Now, for a maximum of 1 month or 4 weeks, giving the full dose of any treatment, it's only then that we can conclude that the treatment is a failure. But approximately about 50% kung na-reach natin yung 50% reduction in the symptoms, that's really very good outcome already. Okay? So, sa umpisa, pwedeng combine yung ating analgesic treatments with lipoic acid. Eventually, once the effect of lipoic acid kicks in, we may now reduce the analgesic treatment to the lowest dose possible na functional po ang patient. And of course, we have to be vigilant with drug-to-drug interaction. Okay? Kasi napapansin nyo, pag elderly po ang ating binigyan ng pregabalin or even tramadol, they become dizzy or drowsy even at the lowest dose. And this may lead to accidental falls, which is very dangerous to our elderly patients. Okay? So moving on, what is the role of phylloxyric acid in the management of BPN? Okay? So, meron po tayong mga frequently asked questions. What is the difference between lipoic acid and phylloxyric acid? Okay? So, lipoic acid is synonymous with phylloxyric acid. If we may add, at a dose preparation of 600 milligrams, a tablet, it is a drug or medicine. It is not a supplement. Okay. So lipoic acid has derivatives or metabolites, no? We call them in the reduced form the dihydrolipoic acid, also the lipolysis. Okay? So La is also called phylloxyric acid. So phylloxyric acid is the terminology in Europe. So they have two enantiomers, the biologically active R isomer and the S isomer. Now, lipoic acid can be found in many vegetables like spinach, broccoli, ganito ba dinner niyo tonight, tomato, Brussels sprouts, rice bran, even the meats and entrails like the liver and the kidney. Okay? Now, pero syempre, before you can have that 600 milligrams, napakaraming kailangan mong kainin vegetables. No? And we promote it din naman with our Pinggang Pinoy. Okay? So ALA can be synthesized by enzymatic reactions in the mitochondria from octanoic acid and cysteine. Okay. So marami na po ang literature data on the use of ALA and DHLA. Okay, at the level of the mitochondria, so going back to the Banting lecture, it acts as a metal chelating agent at the level of the mitochondria. It's a free radical scavenger. It regenerates endogenous antioxidants such as your glutathione, vitamin C, vitamin E, and it repairs oxidized damage. Now, yung existence of the thiol group in the lipoic acid is responsible for its metal chelating abilities. It's able to increase the glutathione level inside the cells, in the mitochondria, and chelate and excrete a wide variety of toxins, especially toxic metals from the body. When we take lipoic acid, it will lead to a decrease in iron ions in the epithelial cells. Okay? And this elevated cell resistance to hydrogen peroxide challenge, meaning your lipoic acid exerts a direct impact on oxidative stress reduction, which is the reactive oxidant species. Okay? So in summary, your lipoic acid or theoctic acid is a biological antioxidant, both water and fat soluble, capable of neutralizing ROS everywhere in the body, inside and outside the cells. And for this, theoctic acid is referred to as the universal antioxidant. Okay? So regarding the pharmacology, it has a very short half-life and bioavailability of about 30% due to the first pass effect at the level of the liver. Okay? And it's unstable in the stomach. Therefore, we have to be giving special instructions to our patient. It should be taken at least 30 minutes before or at least 2 hours after eating. And dose adjustment is not necessary in patients with CKD. Now, this is a meta-analysis, the numerous randomized controlled trials and meta-analysis showing that your theoctic acid improved neuropathic symptoms while reducing the use of rescue medication in type 2 diabetes patients with symptomatic polyneuropathy. Meaning, if you give it first or together initially with your gabapentin, pregabalin, or tramadol, eventually the patient will need to reduce the dose of your tramadol, gabapentin, and your pregabalin. Okay, so case in point, I would like to share with you two of my patients. Okay, one has prediabetes, so this is the case number one. She is MI, a 43-year-old female, a housewife, diagnosed to have prediabetes, hypertension, dyslipidemia, and obesity. And based on the A1C and FBS, so she has prediabetes. Also, the 2 hours post-OGTT is prediabetes. Okay? She came to us complaining of paresthesia on both hands and feet of a year. We did the Michigan Neuropathy screening, which revealed abnormal results. Okay, so we gave her metformin, ARB, statin, and theoctic acid at 600 milligrams daily, 30 minutes before breakfast. We also referred MI to our friends, diabetes educator, nutritionist for medical nutrition therapy and physical activity. And we asked her to follow up after 2 weeks. She came back very happy with the resolution, full resolution of the paresthesia. Okay? And lastly, we have a second case, a long-standing diabetic. She's BL, 64 years old, male rather, a retiree, with diabetes.
FDX 412.
Okay. She also has diabetes stage 3BA1. Okay? So the A1C is 15%, FBS 412. She came complaining with painful pricking sensation on both feet 3 years ago pa nag-start and causing disturbed sleep, which was not relieved by pregabalin. The Michigan neuropathy screening revealed abnormal results, and she already has loss of protective sensation. She was started on insulin, an SGLT2 inhibitor, and phylloxytic acid at 600 milligrams daily before breakfast and referred to a diabetes educator for food care and to a nutritionist for MNT. She followed up weekly so that we were teaching her and training her how to titrate the insulin to reach the target goals. Okay? Now, as she was coming back weekly for successive 4 weeks, within a month, she said, Doktora, mas nakakatulog na po ako ngayon. It's been more than 3 years since I had this feeling of complete sleep. Okay? Okay. So, again, friends, these two cases were based on two real patients of mine. Okay? So, in summary, TPN is an early complication of diabetes, even in pre-diabetes. It is underdiagnosed and undertreated and greatly affects the quality of life of our patients with diabetes. So therefore, we are being called to act very early to give pathogenesis-derived treatment very early. And during the initial phase, we can give multimodal treatment, meaning we can add on rescue medications for severe pain and later on down titrate them. And we also learned that the current pain treatments have their limitations due to the side effects, mostly central acting side effects. So phylloxytic acid, hopefully we will able to convince you that it's able to address the pathophysiologic mechanism of TPN, and it is effective in both the early and late stages of diabetes. Okay, so that will be the last slide, and we can share the references used in the module. If you want to, we can request for WAG for that. Okay guys, I'll be stopping sharing, and guys, thank you mga kapatid. Good night.
Thank you so much, Dr. Duran, for that very simple but yet very and extensive discussion on polyneuropathy. I hope guys, marami kayong natutunan. Now we go now to our main topic for tonight. So, marami sa atin hindi na tayo nakakabiyahe. So, kaya marami nang hindi nag-update sa mga development, only kung masipag tayong magbasa, at dapat maging masipag tayong magbasa. So the PSD decided to have a topic on the update of the recent 2021 American Diabetes Association. This is not only an update, but the highlights of the convention. So tonight, I'll introduce to you our speaker, a Doctor of Medicine in FEU and a faculty of UERM, ISDFI, the head of the ISDFI Research Unit, the past president of the PSD, and an active consultant in Cardinal Santos Medical Center and a visiting consultant in Pasay General Hospital. With that, I'm proud to present to you Dr. Ernesto Ang.
To present the top data and other highlights of the 81st Scientific Meeting at the ADA last June 2021. Now, before I start, I would like to take this opportunity to thank the Philippine Society of Diabetologists for the invitation to be a part of this special edition lecture. So let us begin with my disclosure. So I want to disclose that I have no conflict of interest in the presentation that I will cover today. However, I would like to remind the listener that the presentation will be just a summary of the numerous topics that I chose, which I believe to be important. Since it's just a highlight, with so limited time given for this presentation, the audience therefore is advised to search or log on for more detail. So these are the highlight topics that I would like to cover. First is COVID-19 and diabetes. And I believe in all convention, international and local nowadays, whether it's a diabetes convention, hypertension, cardiovascular, or OBGYN, or any field for that matter, there's an allocated topics for COVID-19 in relation to the disease specialty. So I included the topic on COVID-19 and diabetes, topic on diabetes and obesity, and an interesting topic about COVID and lipids. Then highlights on several trials, both clinical and pharma uh, studies, such as the incretins, SGLT2 inhibitors, and I included new insulin in the development. In the miscellaneous, it's the discussion on combination therapy for type 2 DM, and we will hear from four expert views on the different combination of agents. Uh, Let us see how DM affect COVID-19 outcome. Patients with DM had worse outcomes, especially worse in uncontrolled. Uh, Type 2 DM is associated with higher death rate, but diabetics with better control blood glucose die at a lower rate. On your right, you can see poorly controlled with blood sugar of more than 180. The death rate is 11% compared to well-controlled 70 to 180 milligrams per deciliter. Survival rate can reach up to 98.9%. Okay. DKA is a life-threatening acute complication of diabetes. Okay, and this is in U.S. data. Despite an increase in DKA hospitalization rates, the age-adjusted DKA in hospital case fatality rate has declined over time. However, during pandemic, we witnessed the increase in frequency and severity of DKA as well as case fatality rate. And these have been hypothesized of a potential diabetogenic effect of SARS-CoV-2 virus that uh, responsible for COVID-19 infection. Okay. Now, before we look into the possibility of SARS-CoV-2 or the virus that affects the beta cells, let us first look into obesity as a risk factor because most, if not type 2 DM, are overweight or obese to start with. This is Professor Navid Satter of University of Glasgow in his lecture on obesity and diabetes risk factors for severe COVID-19. The epidemiological evidence shows approximately 5% excess risk severe COVID-19 per BMI unit. Okay, that is seen higher in younger age group, and approximately 12 BMI unit loss by intervention by a bariatric surgery leads to a 69% lower risk of hospitalization and ICU admission. Now, the potential mechanism, according to Professor Sutter, may be multiple reasons. No? The obesity and excess ectopic fat affects negatively the lung function, reduce cardiorespiratory metabolic reserve, and increase immune hyperreactivity. All of these leads to increase in severity from COVID-19 infection. Now, let us see how hyperglycemia affect patients with COVID-19 infection. This is a lecture taken from Professor Antonio Cirillo from Milan, Italy. You remember that Italy was the second country that was hit hard after China early in the pandemic. So when we look at the forest plot, it is not clear is people with diabetes have a higher probability of to be infected. But what is clear from this meta-analysis that if they get the infection, there is a very high probability to have a poorer prognosis. So hyperglycemia and its effect on COVID-19 infection, this is by Alberto Copilli. This is taken from PISA COVID study, shows it is associated with poorer prognosis. Moreover, hyperglycemia in non-DM patients, which is called stress hyperglycemia, can even be more dangerous than people with DM. The survivor curve is poorer with stress hyperglycemia as seen in these slides. However, poor control and stress hyperglycemia carries a poorer prognosis is not exclusively seen in COVID infection. It can be seen in any severe infection or any serious illness for that matter. At any rate, Professor Cirillo gave us a possible mechanism on why type 2 DM or diabetes are very uh, have poorer prognosis when they are infected with COVID. Okay. Now, here's SARS-CoV-2 virus can give rise to cytokine storm, and more importantly, it may affect beta cell function. On your right, it has some out-of-C evidence or evidences that islet cells are susceptible to damage by the virus, and it exhibited necrosis of beta cells and induces beta cell death. Now, what happens if you control inpatient blood glucose? It says here that it improves survival, especially in stress hyperglycemia and severe hyperglycemia. If you can control blood sugar by insulin infusion, it improves prognosis. So there is a interesting data presented by Dr. Kenneth Fingold, the connection between lipids and COVID infection. The effect of infection on lipid in general, it decreases total cholesterol, LDL, HDL, ApoA1, ApoA2, and B levels. However, triglycerides is increased. And it occurs with any infection, bacterial, viral, or parasitic. The mechanism involved is the release of a cytokine from the white cells, and it decreases ApoB secretion and increase in LDL receptors activity that is seen in human hepatocyte cell line. While mechanism of increase in triglycerides is also cytokine, and some cytokines increases free fatty acid, increase de novo fatty acid synthesis, increase triglycerides, increase VLDL, and also reduce clearance of triglycerides. Now, with COVID infection, it's the same effect on lipids, low LDL and HDL, etc. And it has been shown that low LDL and HDL predict severe disease and mortality in COVID infection. With all this data, the question is, is it safe to use statin before or during COVID infection? Okay. So in the next session, the next presenter, Dr. Alan Remley of the National Institute of Health, okay, gave us the potential role of lipid and lipid therapies such as statins, fibrate, HDL raising drugs in modulating COVID-19 infection. And there are some small studies that do suggest the use of in-hospital statin may reduce risk of mortality with COVID infection. Now, there are also many observational trials that have shown some benefit in patients with various causes of pneumonia, either bacterial or viral, with the use of statin. Okay, the upper curve, that's a very large data. Okay, in the lower curve, it is in COVID, which shows similar pattern. Okay, Dr. Remley presented several ongoing lipid modulating trials in COVID-19. The only big randomized trial right now is still ongoing with the use of icosapent ethyl. Now, icosapent ethyl is a highly purified icosapentaenoic acid, and according to Dr. Remley, we just have to wait for a few months for the official result. And just to give you an update, the study result was already disclosed during the ESC last August 2021 that icosapent ethyl trials offers no benefit for prevention of COVID-19 infection in high-risk patients. Now we go to the top line data on pharma and clinical trial. We start with incretins. This is SUSTAIN 40 study. It's a head-to-head comparison of glycemic lowering effect of semaglutide 2 milligrams per week versus 1 milligram per week on metformin with or without SU therapy. The semaglutide 2 milligram per week, the higher dose, reduced the A1C by 2.2% versus 1.9% with the lower dose of semaglutide 1 milligram per week. Okay, weight reduction was 0.93 kilogram more with a higher dose of semaglutide. Now, the next is twincretin. Okay, what is twincretin? Okay, it is terzepatide. It is a novel once weekly GIP as well as GLP-1 receptor agonist. One molecule that is attached into these two receptors. No, the study shows the study have shown superiority compared to semaglutide or basal insulin as an add-on to metformin or insulin, and as monotherapy for type 2 DM across 4 phase 3 clinical trials. Tirzepatide shows superior results in A1C, fasting plasma glucose reduction, and weight loss across the 4 SURPASS clinical trials. SURPASS is the clinical trial program of tirzepatide. Okay, SURPASS 1, 2, 3, and 5. Okay, let's go quickly with the clinical trial results. Okay, SURPASS 1 is in type 2 DM, tirzepatide given in type 2 DM that is inadequately controlled with diet and exercise versus placebo. And you can see the result that there was a greater A1C reduction and fasting plasma glucose with tirzepatide on a dose-dependent manner compared to placebo. Weight loss on a dose-dependent manner again seen in tirzepatide and compared to placebo without weight loss. Okay, for SURPASS 2 is tirzepatide versus semaglutide as an add-on therapy to metformin, and you can see that A1C reduction after 40 weeks, greater A1C reduction, and fasting plasma glucose with tirzepatide on a dose-dependent manner compared to semaglutide. Even the lowest dose of tirzepatide had greater A1C and fasting plasma glucose reduction versus semaglutide. For weight loss, more percentage of participants have greater weight loss, either at least 5% or 15% compared to semaglutide. In SURPASS 3, this is tirzepatide versus insulin degludec. Tirzepatide, as you can see, showed greater A1C and fasting plasma glucose reduction in a dose-dependent manner, and even the lowest dose of tirzepatide had greater A1C reduction as well as fasting plasma glucose than degludec. Only 5% of patients had an A1C of less than 5.7 in degludec versus 26, 39, and 48% of the tirzepatide patients at the 3 different doses. In terms of weight, up to 13.9% loss with tirzepatide, while insulin degludec group increased by about 2.5 kilograms. Okay, so for SURPASS 5, it's tirzepatide versus placebo add-on to insulin glargine. And you can see same pattern with greater reduction of A1C and fasting plasma glucose with tirzepatide, again on a dose-dependent manner, versus glargine. With weight reduction seen in tirzepatide on, again, dose-dependent manner, while glargine, there was an increase in weight by 2.2 kilograms. Okay, the data on tirzepatide are very impressive and unprecedented. Okay, the SURPASS data presented their clinical efficacy findings, and of course, will not give us the mechanism involved. However, in a separate session entitled New Turf for the other incretin, which pertains to the GIP signaling in the brain and the effect on food intake and energy balance, there are four researchers, all are PhD, presented the possible mechanism based on the animal as well as cell line studies because it's difficult to study human brain. The first, Dr. Fukuda was the first of the four researchers to discuss GIP signaling from the animal brain studies. And according to him, GIP signaling from the gut to the brain can induce leptin resistance to increase obesity. This is why GIP pharmacological research and development lag behind GLP-1. For Alice and Adriansens, however, combining the two, GIP and GLP-1 or the dual GIP and GLP-1 receptor agonism can reduce adiposity. For Dr. Peirce's study using integrated single-cell line data shows GIP receptors are concentrated in the area of post-strema, which are GABAergic neurons, which is implicated as a chemoreceptor trigger zone for vomiting, and GLP-1 are concentrated of the same area, but this time it has GABAergic as well as glutaminergic and the nucleus tractus solitari or NTS, which is glutaminergic neurons. So, what's the meaning of these studies? Okay, Dr. Hayes, the last speaker of the University of Pennsylvania School of Medicine, explained, okay, that this data taken together showed that GIP receptors on the GABA neuron seems to be the most active in blocking the nausea and vomiting response to GLP-1 agonism. Okay. He further explained that hunger, satiety, nausea, and vomiting are all points on the same curve of ingestive behavior. If you push too far, you move from satiety and fullness to nausea and vomiting. It turned out in their experiments that GIP receptor agonism blocks GLP-1 receptor mediated emesis while maintain the metabolic benefit of GLP-1 agonism. In other words, okay, GIP receptor when activated by GIP blocks the nausea and or emetic responses to GLP-1 receptor agonism that perhaps explain the robust A1C reduction and weight loss and lower hypoglycemia event with the other GLP-1 receptor agonists alone. Okay, now we go to peglitide, and this is a glucagon-like peptide 1 receptor agonist based on structures of exendin 4. Okay, now it is conjugated with a Fc fragment or fraction of immunoglobulin G. This is to prolong the half-life, so this is given once weekly, just like the mechanism involved in dulaglutide. Amplitude O is the cardiovascular outcome trial of epigrenetide and was designed to determine if the effect of an exendin 4 base GLP-1 receptor agonist are similar to other agents in the class. In other words, comparing exendin 4 based GLP-1 with GLP-1 analog with regards to cardiovascular benefit. Since ELIXA and EXCEL, which are both exendin 4 mimetics, the cardiovascular outcome trial were both neutral and without CB benefit. So let me just go right away with the result. In this CVOT, amplitude O, there was 27% lower risk of MACE, 21% lower risk of expanded MACE, that's MACE plus coronary revascularization or hospitalization for unstable angina. 32% lower risk of composite renal outcome, 27% lower risk of MACE or non-CV death. Okay, so therefore, clearly, this is the first positive GLP-1 receptor agonist with CVOT with an exendin 4 based GLP-1 showing cardioprotective effect. And this is the main message of the study. Okay. Now we go to incretin for obesity trial and treatment. It's a step, constellation of studies. Okay, looking at the anti-obesity effect of a higher dose of semaglutide 2.4 milligrams per week, which has been approved by the US FDA for the management of obesity. Okay, weight loss of about 15% when used in conjunction with diet and lifestyle modification. It's very impressive because one-third of the patient lost more than 20% of body weight. Step 1 study is for anti-obesity, examine weight management, showed that when used in patients with pre-diabetes, higher likelihood of preventing progression to diabetes. Remember that these are populated with non-DM patients and pre-diabetes. Step 4 studies is to investigate the sustained weight management. In the study conclusion, once again, it emphasized that anti-obesity treatment needs to be continued long-term because discontinuation can often lead to a rebound increase in weight. Uh, uh, this is because uh, obesity is a chronic disease. So let's go now to SGLT2 inhibitor trials. No? We have the DARE-19 trial with dapagliflozin, scored and soloist with sotagliflozin, the dual SGLT1 and 2 inhibitor. So the DARE-19 trial was a large RCT of SGLT2 inhibitors to address the potential benefit and risk of this agent in patients hospitalized with COVID-19. When AstraZeneca announced and launched the DARE-19 study, an SGLT2 inhibitor in COVID inpatient have raised a lot of eyebrows from the experts, since the recommendation is to discontinue SGLT2 inhibitor in a sick inpatient because of a concern of potential risk of AKI or acute kidney injury and DKA. So therefore, DARE-19, well, I would say, is basically a safety rather than efficacy trial. So more than half of this trial had type 2 DM, and the main reason of using this agent in sick hospitalized patients is that SGLT2 inhibitor have demonstrated previously to provide organ protection in type 2 DM, such as heart failure and CKD. Okay, so here's a perfect picture that depicts how they rationalize the use of dapagliflozin in COVID-19 infection. On your left, the known clinical benefit of SGLT2 inhibitors such as increase in endothelial function, decrease oxidative stress, decrease inflammation, decrease insulin and insulin resistance and glucose. This leads to improvement in hypertension, hyperglycemia, heart failure, CKD, and obesity. On your right, the effect of COVID-19, which is the reverse of the benefit that you see in SGLT2 inhibitors, such as decreased endothelial function, increased oxidative stress, increased inflammation, as well as increase in insulin resistance. This may lead to hypertension, hyperglycemia, heart failure, CKD, and obesity. So SGLT2 inhibitor seems to counteract most, if not all, of the pathological effect of COVID-19 infection. So let's go right away with the key result. Dapagliflozin did not statistically affect organ failure or survival, okay, although numerically fewer events with dapagliflozin than with placebo. Okay. There were a lot of potential safety concern about using SGLT2 inhibitors in acute setting, including things like a volume depletion, acute kidney injury, and DKA. However, in their 19 study, there were fewer serious adverse events with DAPA versus placebo, numerically fewer fatal serious adverse events with DAPA versus placebo, numerically fewer adverse events leading to discontinuation of study medication, and numerically fewer serious adverse events of acute kidney injury. There are there were two cases of diabetic ketoacidosis or DKA. Both of them are diabetics. Uh, However, eventually they recovered. And according to the author, uh, the results are promising, and it generates the hypothesis that dapagliflozin may provide organ protection in this patient population. In addition, DAPA was well tolerated in this study and no new safety concerns were identified. This is a very important finding that has an impact on clinical practice. Okay. Now, let's go now to sotagliflozin, a dual SGLT1 and 2 inhibitor. Okay. The combined activity of SGLT1 and 2 inhibitor will have greater benefit for glycemic control even in patients with diminished GFR or in moderate to severe CKD. Soloist is for post-worsening heart failure endpoint and scored study looking on the renal as well as CV endpoint in type 2 DM with moderate renal impairment. Okay, the soloists, um, these are patients with heart failure that were stabilized in hospital before randomization to treatment with sotagliflozin or placebo. Where the criteria for stability are: number one, no need for oxygen, okay, systolic blood pressure at least 100, no need for IV inotropic, and transitioning from IV to oral diuretics. And the result shows a significant lower risk of death from cardiovascular causes and hospitalization or urgent visit for heart failure. Okay. The score is to assess the safety and efficacy of sotagliflozin in reducing CV events among patients with type 2 DM and CKD. Just to give you the highlights, SOTA reduced A1C significantly. Results shows the cohort of patients receiving sotagliflozin had a 26% reduction in the numbers of CV deaths, okay, hospitalization for heart failure or urgent visit for heart failure. Additionally, a 23% decrease in MI and stroke that was observed, presumably due to inhibition of SGLT1 inhibitor or inhibition. So this is a slide uh, showing sotagliflozin can exhibit dose-dependent effect on glycemic efficacy. However, glycosuria remain the same, meaning, okay, no increase in urinary excretion, in increase in dose in stage 3 and 4 CKD, and yet there is a significant reduction in glycemia. This will explain the glucose lowering effect of SGLT1 inhibitor in or inhibition of glucose absorption in the small intestine. Now, we have robust data of SGLT2 inhibitor for heart failure prevention. We we also have enough data for heart failure treatment, and but now uh, may not be only heart failure treatment but may also be treatment for acute worsening, and this is the message of the study according to the authors. Now, combining soloist and scored and compare it to other SGLT2 inhibitors CVOTs. Number one, the ability to lower A1C in patients with severely depressed renal function because of the inhibition of additional inhibition with the SGLT1. Sorry. Number two, safe initiation in patients recently hospitalized for heart failure. And this is the first prospective data to show improvement in patients with heart failure and preserved ejection fraction. However, it's not that large data and it's not a dedicated trial. A higher level of protection against MI and stroke than the SGLT2 inhibitor that we saw in the cardiovascular outcome trial. So we go now to GRADE trial. It's a comparative effectiveness study of the major glycemic lowering medication for treatment of type 2 DM. GRADE was designed to guide the choice of glucose lowering medication that would be added to metformin based on the effect on A1C, duration of effectiveness, effect of complication, tolerability, and adverse effect. No? Recruitment of this patient was way back in 2013, wherein we don't have yet the present ADA treatment guideline incorporating all this CBOT evidence, especially agents that are recommended for CB and renal protection. The data presented at the ADA June 2021 were a preliminary analysis, since at that time of this presentation at ADA, not all events are fully adjudicated. And in fact, SGLT2 inhibitors were not included, either not yet approved in the early recruitment, or they have a very low use or insufficient experience with SGLT2 inhibitors. Okay, the first SGLT2 is canagliflozin, that wasn't approved in the US until after GRADE had been planned, funded, and initiated. In addition, TCD was not included because of concern of adverse events at that time. Now, let's go now to the metabolic outcome. Okay, there are primary metabolic outcomes, secondary, as well as tertiary. So, the primary outcome, primary metabolic outcome is defined as percentage of participants who develop an A1C of 7 and above. Okay, and and you can see that the highest percentage was seen with the sitagliptin, 77%, followed by glimepiride at 72%. The lowest were glargine and liraglutide, meaning better agent in terms of primary metabolic outcome. The secondary outcome is percentage of participants who develop an A1C of more than 7.5%. Okay. Now, glargine, you can see, was significantly more effective in maintaining A1C in the target range than liraglutide, which in turn was more effective than glimepiride and sitagliptin. Now, with the tertiary metabolic outcome, which is defined as an A1C of more than 7.5 after reaching secondary outcome. The tertiary metabolic outcomes was reached by 26% on glargine and liraglutide, the same, 30% on sitagliptin, and 31% on glimepiride, meaning glargine and liraglutide were better. Okay, there is also a microvascular outcome, and the microvascular event, including nephropathy and neuropathy, were pretty similar across the drug group. With regards to any CVD that is listed there, liraglutide seems in this preliminary result to reduce the risk of any cardiovascular event, although all of these data are not yet fully adjudicated. So as far as the adverse event and side effect summary, gastrointestinal adverse events are common in liraglutide group. For severe hypoglycemia, the most common is with glimepiride followed by glargine. Weight loss was greatest with liraglutide and sitagliptin followed by glimepiride and glargine. So the final grade conclusion by the authors, the grade cohort was highly diverse, reflecting the population with diabetes in the US. Grade has shown that the four medications differ with regards to their metabolic effect over time, CV risk, and other clinical important factors. While the grade findings will prove valuable in guiding treatment, they may be blunted by the exclusion of SGLT2 as the fifth agent or comparator. Now we go now to the new insulin. These are presented as an oral presentation under clinical diabetes therapeutics. So I included the following. Number one, the ultra rapid Lispro or URLI versus Humalog in type 1 DM on insulin pump. Number two, once weekly basal insulin FC or the BIF. Number three is the co-formulation of insulin and pramlintide. So the ultra rapid Lispro is basically Lispro rapid analog in which two components or excipients were added. Number one is the treprostinil, is a synthetic analog of prostacyclin, which is a vasodilator, and a citrate, which is a local vascular permeability. And these two components added makes the insulin absorption accelerated and has a faster onset of action. In phase 2 trial, the URLI versus Humalog shows mean plasma glucose concentration versus time after correction of bolus of rapid Lispro or Humalog for hyperglycemia due to missed meal in left or due to basal insulin suspension in right in patients with type 1 diabetes. In other words, ultra-rapid Lispro has much faster onset and earlier recovery than Humalog. Now, let's go now to weekly basal insulin that is fused with Fc portion of human immunoglobulin IgG that makes it a long acting once weekly subcutaneous administration. Well, the mechanism is pretty similar with dulaglutide. Its attributes are as follows. Besides once weekly, it is an insulin receptor selective agonist and less selective with other receptor like IGF-1 receptor or insulin growth factor 1 receptor. So it has a low mitogenicity. It can be co-formulated with weekly incretins. In a phase 2 study looking at glycemic control with once weekly basal insulin (FC) in person with type 2 DM using CGM compared with insulin degludec. The summary and conclusion shows the following. BIF demonstrated lower within-day glucose variability compared to insulin degludec. The rate and relative risk of hypoglycemia less than 70 milligrams per deciliter or slower with BIF compared with insulin degludec. Glycemic control with BIF was non-inferior to insulin degludec despite higher fasting glucose target with BIF. Okay, so the next is the co-formulation of insulin and pramlintide called ADO09. No? Pramlintide is an analog of amylin for type 1. It contributes to prandial glucose control in three ways. One is slow gastric emptying. It can reduce postprandial glucagon. It modulates satiety. Now, it is not mixable with currently marketed prandial insulins and requires 3 additional daily injections. It is a co-formulation with a novel insulin called A21G as a prandial insulin analog that can be mixed with pramlintide. So, the result in this phase 2 trial, when we look at the graph, shows a co-formulation. There is a greater reduction of plasma glucose, reduced gastric emptying, better CGM profile, and reduced glucagon level versus aspart. Okay, for the final one, there are 4 distinguished physician scientists discuss the best DM agent combination. And the title of the symposium is Matchmaker, Make Me a Match, Selecting Glucose Lowering Combination for Type 2 Diabetes mellitus. Okay, the 4 well-known scientists, physicians are following: Professor um, Ralph DePronso, Professor of Medicine and Chief Diabetes Division, University of Texas Health Science Center, Dr. Chantal Mathieu, Professor of Endocrinology, University of Belgium, Tina Wilsbold, Professor of Medicine, University of Copenhagen, Denmark, and lastly, David D'Aliso, Professor of Medicine and Chief of the Division of Endocrinology and Metabolism, Duke University Medical Center. So for Professor DePronso discussed the triple combination therapies that incorporate GLP-1 receptor agonists, SGLT2 inhibitors, and pioglitazone, 3 classes of drugs that have been shown to provide cardiovascular protections. Studies suggest that the benefit of these therapies outweighs the risk of weight gain. And according to Professor DeFronso, the more weight you gain with pioglitazone, the greater the drop in A1C and the greater the improvement of beta cell function and the greater improvement in insulin resistance. While Professor Chantal Matthew uh, discussed the rationale for combining SGLT2 and insulin. Insulin was based on the pathophysiology of type 2 diabetes, which is a progressive disease, and over time you need insulin to adequately control the blood sugar of a type 2 DM. With SGLT2 inhibitors leads to an insulin sparing effect, and it also can help in reducing the weight gain with insulin use. With the meta-analysis studies do suggest that the cardiorenal beneficial effect of SGLT2 inhibitors is preserved in type 2 DM who need insulin for glucose control. But Professor Tina Wisbol discussed the clinical benefit with A1C reduction with less hypoglycemia and lower body weight uh, with insulin plus GLP-1 receptor agonist. However, when insulin is prescribed, compliance is a key factor and patients should be monitored closely when adding a GLP-1 receptor agonist. Professor David Aliso discussed the emerging role of dual and multi-receptor agonists, including tirzepatide, a dual glucose-dependent insulotropic polypeptide, that's GIP and GLP-1 receptor agonist. In human studies, support the dual agonist as an effective way of lowering or lower blood glucose and body weight with tirzepatide, which we discussed a lot with the previous slides. While multi-receptor agonist seems to be promising, but they are still in the development. So with that, I would like to close my presentation and thank you for listening. But before I totally close, I decided to give a little hilarious jokes to ease out our struggles because we are currently experiencing an extremely difficult and challenging time from this pandemic. As you know, it's been more than 2 years now when we started to experience this onslaught of COVID-19 pandemic. Although there might be a silver lining in our present Omicron variant, and some experts believe that this may be the beginning of the end of the pandemic. Although some experts also believe that even if we end the pandemic now, it will take a couple of years more to rebuild from the aftermath of this pandemic. We need to cope up and recover with the clinical, social, economic, and psychological aftershocks of all of these deaths, people in isolation, and all of this disruption. Millions of kids miss school, millions of people will be grieving from the loss of their loved ones, loss of their job, business closed. We are borrowing billions or even trillions of pesos or dollars, and we have to pay those debts, etc. So it would take a couple of years more to recover and be normal again. And some says that they have aged a lot during these 2 years lockdown. The question is, what is really the signs of getting old? Is it gray hair? I don't think so. It's not necessarily because some relatively young individual may have some strand of gray hair, so it's not a good guide. Loss of memory, again, no, since presenile dementia that occurs during the age between 50 to 65 years old, which is relatively young. So it's not a good gauge again. Okay. Wrinkle in the face. Again, science says no, since even young individuals, when exposed frequently to sun radiation or UV light, can cause damage of the skin and can give rise to wrinkles, like farmers, construction workers, etc. So how about doctors' prescriptions and medicine? And you know this that young type 1 diabetes may have a lot of prescriptions and medicine, may have to take a lot of medications. Um, Young individuals who have a lot of comorbidities may need prescriptions and medicines, more prescriptions and medicine, congenital diseases, etc. So how about baldness? I would say no again, since it's mostly due to genetics. So, what then? What is the best guide or gauge? And the answer is when your wife stops suspecting you. So, having said that, let us now look on what is the wife's golden words. Okay, number one, if you want to change the word, do it when you are a bachelor. After, you can't even change a TV channel. Number two, listening to wife is like regarding the terms and conditions of a websites. You understand nothing, still you agree. Number three, chess is the only game in the world which reflects the status of the husband. The poor king can take only one step at a time, while the mighty queen can do whatever she likes. And number four, all men are brave. Horror movies don't scare them, but five missed calls from wife surely does. So again, thank you again for listening, but I really need to go since I have five missed calls from my wife now.
Okay, good. We have a very we have a very ano ba yan? Good laughter to end the lecture of Dr. Ang. Let's have a big round of applause for Dr. Ang for making us for updating us to the newest development, not only in she shows us the new drugs, the different studies, as well as the upcoming new drugs in diabetes. Thank you so much. So if you have any questions, may write it
Marcy,
to the
before we
chat
start,
box.
can you hear me?
Yes.
Yeah. Before we start with the Q&A, let me just tell the audience that just don't get me wrong. I have no issue with my marriage. No? We are blessed with the two wonderful kids, and we are happily married. No, so she is happy and I'm married. And the secret is we subscribe to workshop, and that is I work and she shop. Of course, joke din yun, ano?
Yes, yes. I know you are. You have a very successful marriage. So we go now to the comment.
Ang question? Wala yung question eh. Meron nag-comment, may nag-comment yata na mas nakakatakot yung European na crisis ngayon. Nawala yata.
Yung aking internet. Ernie, can you hear me? I'd like to throw to you the first question. There's a lot of COVID patient who had nagkaroon ng diabetes doon lang sa time na nagko-COVID siya. Nakita ko because of the steroids, but following them, wala naman silang diabetes. Nakaka-diabetes sila. Meron bang binanggit doon sa study doon na detection na or dumami yung diabetes because of the COVID-19, because of drugs that was given with steroids?
When they are admitted, when they have desaturation, that is because of
Nadinig
the...
mo ba ako, Ernie?
Yeah, can you hear me? Hello?
Yes, yes.
I'm saying when patient is admitted and when patient is an non-DN and when they get desaturated, they have organized pneumonia. and this is usually seen in Delta and other variant, and because of cytokine storm. Okay, when they say that the virus enters the the lungs, you produce a systemic inflammatory changes, or you stimulate immune system systemically, no? Hindi kung upper airway lang, IgA lang. Pag IgG, it's more of pro-inflammatory. So in other words, you develop cytokine storm. And with regards to non-DM and admitted, usually we give steroids, and dexamethasone is the most in terms of glucocorticoid, is the most potent, and it's a long acting. So that's why even in non-DM, if they given dexamethasone, they will develop hyperglycemia even in non-DM. Ibang usapan na yon usually after you stop the dexamethasone. If a non-DM, they go back to normal. Now, there was a study, as I presented, that they found out that there are a lot more DKA patients they have more, mas maraming DKA silang nakikita during the COVID infection. So these are diabetic patients, okay, that they develop DKA when they got infected. So they tried to find out if the virus itself can affect the beta cells. And I have presented some histological pattern that they may affect beta cells. No? But this is an evolving data. They're still trying to look at more data to really say the virus, yung virus na pinag-uusapan nila, Delta, ngayon halos Omicron na tayo no? Predominantly Omicron. So I don't know if they can get retrospective data and try to find out if really the virus can really cause a new onset diabetes. It's a evolving data. It's a new data. I think we have to wait a while to see some evidence. At ADA, wala pa silang masyadong evidence, no? O konti pa lang. Yeah, thank you. I think I answered that question.
Okay, thank you, Ernie. How about personally about the use of SGLT2 in COVID patients? Personally, I really discontinued the SGLT2
Okay.
during COVID times of
Yes. That's a very good question. The recommendation is you still have to discontinue SGLT2 inhibitors when the patient is taking SGLT2 when they are admitted in a hospital to prevent acute renal failure, no, from dehydration and other, especially in a patient with diabetes. They may develop DKA, etc., etc. The recommendation is still to stop. But however, their 19 trial using dapagliflozin, they found out that if you close follow-up the patient and you give DAPA, it did not show any increase in these side effects. No, but the recommendation is you still have to temporarily discontinue to be safe. For me, my own opinion, I will try to discontinue. If the blood sugar is high, usually we use insulin as an inpatient control of blood sugar hyperglycemia.
Okay, thank you so much. So I'm just curious with the sotagliflozin, wherein SGLT2 1 and 2 is inhibited. Ano ba yung advantage niya talaga? Ibig sabihin, pwede na siyang gamitin kahit na end-stage kidney disease na?
No, stage 3 and I think stage 4. End stage, wala na masyadong effect yun eh. Okay? So, ang nakikita nila, ang stage 3 and 4, if you give it in the study, they found out that there is still lowering of A1C or blood sugar. You still have some evidence of glucose control, and yet the glucosuria doesn't increase. So perhaps, or most likely, the effect is in the inhibition of SGLT1 in the intestine. That is the decrease in absorption of glucose. So because it's a dual. However, it's not approved. It's not approved here locally. Even in the States, it's not approved because they file an approval because study is for type 1. Okay, so it was not approved in the state for fear of the increasing DKA. But in some country in Europe, it is approved for type 1. Ang in-applyan nila is for type 1 because their clinical trial are based on type 1 patient.
Okay, that clarifies
We
the.
don't have it here. We don't have it here.
Okay. Okay. So wala pala tayo dito, no? Kaya lang na-curious ako sabihin mo na hanggang sa severe type ay pwedeng gamitin.
End stage siguro wala na siguro effect. Yung 3 and 4 nakita nila na may effect pa yung as far as lowering of blood glucose. Now they claim the mechanism may be due to the reduction in the absorption of from the GI tract because it also inhibit partially the SGLT1 which is present in the GI tract.
Okay, kaya pala. Okay. So, how about yung gaano ka yung topic mo regarding with insulin, ano, yung ultra rapid. Gaano ka rapid yun? Yung ultra rapid?
Ultra rapid?
Yeah.
Wala kasi, it's a phase 2 trial. Ang nilagay nila, it's basically Humalog, no? Lispro yun. May dinagdagan silang through dalawang agent together with insulin that will prolong the that will increase the absorption. One is a local vasodilator at saka increase in absorption. Okay? So mas mabilis siya kaysa sa Humalog, okay? So it somehow simulate the endogenous insulin response during a mealtime. But nothing perfectly match the insulin secretion of our pancreas, our endogenous insulin secretion. But it's better compared to Humalog as the study show. It's a phase 2 trial only.
Okay.
So mas madali siya umakyat, okay? At mas mabilis siya mawala. So ang effect noon is pag nag-inject ka, makukuha mo kagad yung postprandial mo at pag hindi siya tumatagal at hindi ka nagko-cause ng hypo, mas less ang hypo mo. So it is better in terms of pharmacokinetic, in terms of postprandial effect on blood glucose concentration after a meal.
Okay. Kung iyan naman ay less ang hypo, baka less ang hypo sabi mo, no? Pero yung siguro yung basal insulin once a week, that could precipitate more hypo siguro to.
Doon sa study, hindi. In fact, nakita nga nila better A1C, less hypo. It's a very early study. Again, it's a phase 2. So we will see the development, how will it be. Now, I want to discuss about the FC fragment, no, FC portion. Yan nakalink yung agent, nakalink sa IgG, the FC portion, no. When it links, it becomes a macromolecules and it prolongs the half-life. How it prolongs the half-life? There's a reason. One reason it's if it's macromolecules that like albumin, hindi yan masyado na-filter sa glomerulus, no? So it stays in the blood longer. Number 2, meron silang tinatawag na FcRn, which is in the cells there is what you call neonatal receptors, no? Usually Pag pumasok yun, nadidegrade ng lysosomal enzymes yung agent. But this one, these receptors attaches to that and nilalagay niya uli sa surface, hindi niya pinapa-digest o degrade. Kaya humahaba ang life, ang half-life. Kaya giging once a week. That is the same principle with dulaglutide. And dulaglutide, as you remember, it's once weekly. Kasi you can prolong the half-life and give it once weekly in several ways. You can mix it with albumin, like albiglutide, nakamix yun sa albumin externally, and then you have to inject it, and then it is bound to albumin when it is absorbed, and the half-life is prolonged. Okay. Ang problem lang, it's if you inject it, if you link it exogenously with albumin, napaka-thick ng solution, saka malaki. You need a higher bore syringe, etc., etc. And this one mechanism is you just inject the agent with FC portion, so it also prolong without having a very large molecules giving it subcutaneously. So yan ang isang mechanism how to prolong the half-life of a pharmacological agent.
Okay, yun pala yun, ano, yun pala yung new pharmacological yung structure nila kung bakit sila napoprolong. Merong tanong dito si Jamie, no? How about SGLT2 among type 2 diabetic pedia? Meron po ba ada update?
Come again?
Modi siguro to. Meron ba daw update doon sa type 2 diabetes na pedia? It's been Modi. With the use of SGLT2.
Wala akong alam na merong topic na pedia SGLT2. I don't know if there is. Kasi ang program naman, if you look at the program, it's a 1-week program. It's simultaneous, napakarami. It's absolutely impossible to cover all, no? But I don't remember there is a pedia portion, an SGLT2 used in pedia. I'm not sure. Maybe there is, he can share. I missed it or what? Wala. Ang alam ko lang, meron silang ADA-ESD recommendation initially, and it was finalized in the EASD convention regarding type 1 DM sa adult, sa older patient. No? Ano ang mga recommendation nila?
Yes. And that will be the future topic in our PSD Select. So with that, wala na ba kayong question? I think it's we call it a very fruitful night, no? Ay, announcement, Ernie, we Nora Calidad Hipolito. Thank you and congratulations to our speaker. Salute to Dr. Ang for giving us a very good synopsis and update information from last ADA. With that, I say thank you very much, Ernie, for giving us a very wonderful lecture as well as a wonderful Q&A. Sana ma-invite ka ulit namin in the future. Thank you so much.
Okay, you're welcome.
Thank you po, sir.
Yeah, so next time, I hope we see each other again on March 26, 2022. On our next topic will be, Lynn, can you have the next topic? So our topic will be, where are we now in the battle of COVID-2? In the battle against COVID. So this will be, our speaker will be Dr. Solante. And we have a CME grant with OEP. Speaker is Dr. Lourdes Ella Santos. Alam niyo naman, pag si Ella Santos, tiyak lipid siyan. So hope to see you next time. I hope you have a wonderful time learning tonight and stay safe. God bless.